Welcome to the Drip Podcast. Today's guest is a clinical nurse specialist and CEO of her nursing consulting agency. She is the content creator and author of many lectures, books, guides, and supports nurse education and development for critical care. She received her undergraduate degree from Purdue University and her graduate degree from the University of Washington. She is on the Healthcare Advisory Board for Baxter and Vivint, and also a contributing member of AACN and SCCM. Along with her popular books on critical care survival, she has published over 30 peer-reviewed papers. She is passionate about new critical care literature and translational science. Please welcome Nicole Kupchik.
Welcome, everyone, today to the Drip Podcast. And I am your host, Angela Craig. Clayton is out today, the co-host. So it's just going to be Nicole Kupchik and I. Woohoo! We are so excited that Nicole is with us. How lucky are we to get to just pick her brain today about fluid types in different disease states. So Nicole, welcome. It is so awesome to have you here with us. I just would love for you to share a little bit about yourself to get started.
Yeah, thanks, Angela, and thanks to Baxter for having me. So I'm a clinical nurse specialist. I've been a nurse for over 30 years, and my specialties have been anything in critical care, including cardiac medicine, anything respiratory. I founded with a team, a sepsis program, was a code blue chair. So I've gotten to do a lot of really cool things in my career.
That's awesome. You've done so much for, you're being really eloquent because let's just everyone talk about Nicole Kupchik and all she has done for critical care. We could go on and on and on. And anytime anybody gets the opportunity, whether it's at AACN's NTI or to hear her speak or around the country, all the classes that she does on certification, as well as all the, let's just talk about the books you've published and the articles you've written. So she was being very humble, but we are blessed to have her with us today. And just, I think for me, the most important thing is how passionate she is to really make a difference in the lives of our patients. And I think that's where it's at, right, Nicole? Just caring for our patients to the best of our ability and being able to change their outcomes potentially.
Well, absolutely. And as a clinical nurse specialist, one of the things that we get to do is translate science into practice. And, you can do studies until the cows come home, but if you don't have someone at the bedside level, looking at the studies and critically evaluating them and asking like, will this work in my facility? And are we practicing at the highest level of science? Then, these studies are honestly pretty useless. So it's just really important that hospitals pay attention and change practice when the literature dictates that we should do so.
Absolutely. Oh gosh, if every place could have that culture, right, and mentality, I think we would be living in a different world, really. All right. Well, we are honored to have you with us today, and we could talk about what we've already been discussing the whole time as well. But we're really going to try to focus on, want to just talk about fluid types, and then maybe about the trend to move more toward balanced solutions. So I thought maybe we could start with just fluid types and discuss them really quickly about the differences.
Yeah. Well, one of the things I always say is you need to know why you hang what you hang, right? And, fluid is not benign. Too much can cause problems. Too little can cause problems. Not using the right one can cause a lot of problems. And so I think that's one of those things. I just felt like, it's been a long time since I've been in nursing school, but I don't think we talked about this at all when I was in nursing school. And so if we first just kind of just mention isotonic solutions and, typical crystalloids we give at the bedside, I think it's just really important to understand that there are major differences between saline, LR, and plasma IA, which are the three most common used fluids, at least in the United States. And, so saline, I think for years and years and years was our go-to fluid choice. But there are a few things you really need to understand is number one, it's a very acidic fluid. And one of the things I always joke around is just joke with people and say, yeah, so how many of you read the paragraph on your IV solution bag? And pretty much everyone looks at me like I've got a third eyeball in the middle of my head, but truly, like when you look at like your IV solution bags, it spells out what the components of that fluid are, including like the pH, the osmolality of the fluid, what electrolytes are in the fluid. And saline has been our go-to for years and years and years and years. And it's very acidic. So saline has a pH of 5.5 to 5.6, depending on which company, you're looking at, right? The osmolality of it is it's close to being, close to our serum osmolality. So it's, should stay in the vasculature when you give it. But it also has a lot of sodium. It's got a significant amount of sodium in it. And I think people just don't realize, like, for example, it's got 900 milligrams per 100 mils. Stop and think about that. 900 milligrams of sodium chloride per 100 mils. And so, a liter of saline has got about 9 grams of sodium in it. It's got a ton of sodium. And then it doesn't have potassium, and it's very rich in chloride as well. And it's the chloride we think is causing a lot of problems in patients. And so, the chloride in saline is about 154 milliequivalents per liter. So it's very, very rich in chloride and sodium, thus the name sodium chloride. However, I think a lot of us called it normal saline. One of the challenges I was put out there to nurses or whoever will listen to me is to stop calling it normal, because it's acidic and it's very rich in sodium and chloride. And so there's nothing normal about saline. And there's a long history behind like why saline has been used over the years. You'll find varying histories, but it's interesting. If you look at LR, so lactated ringers, I think, is probably coming to be one of the most commonly used fluid now. It's got a pH of 6.75, so it's definitely not as acidic. The osmolality of it's 273, so it's super, super close to our serum osmolality. The sodium is 130 milliequivalents per liter compared to 154 in saline. So there's a lot less sodium. The chloride is 109 milliequivalents per liter versus 154 in saline. So again, big differences there. It's got a little bit of potassium, 4 milliequivalents per liter. And a lot of people are like, oh, I can't give this to my hyperkalemic patient. Well, actually, there have been a few studies demonstrating that when you do give a liter of LR, it's diluted in so much fluid that you can actually bring the K down. So, hyperkalemia is one of those old wives' tales. And, the other thing you'll hear people say is like, oh, I can't give my patient lactated ringers or lactate is elevated. Well, it's sodium lactate. It's not the same type of lactate or lactic acid that you build when you're hypoperfused. So, there's a lot of misconceptions about LR. And then plasmolite A, if you were to take a look at that, it's got a pH of 7.4. The osmo is 294, so very close to our serum osmolality. The sodium's 140. Again, saline's 154. The potassium's 5, so it's a tiny bit higher than LR, but not much. And then the chloride is 98 milliequivalents per liter versus 154 in saline. So, big differences. And if everybody's wondering, like, where did she get all those numbers? I literally just grabbed a bag of IV fluid and looked at what the paragraph said below the name of the solution. So that is literally where I got that information.
Yeah, that's some great information. And I think there's been quite a bit of literature recently, when I say recent, in the last 5 years, wouldn't you say, that really supports more of a balanced solution approach. Now, my question to you is, would you say that most of the studies that support a balanced solution are with the sepsis population, or what are you seeing in the literature for maybe the different disease states? Or we can kind of go through some different disease states if you'd like, however you want to tackle that.
Yeah. Well, so first of all, let me just back up. And for those of you who may not be aware, what we mean by balanced solutions. And so, for example, like LR and plasmolite A are considered to be more balanced because they don't have, like, they're less acidic and they're not rich in chloride and they don't have a ton of sodium, whereas saline would not fit that category of being balanced because it's got so much chloride, it's acidic. And so just to kind of, when we say the word balanced fluid, we're usually referring to LR and plasmolite A. Now, as far as studies, I think that the two studies that really kind of put things on the map as far as like having us really question what we're giving at the bedside as far as a crystalloid would be the SMART study that was published in 20, I think it was published in 27, No, 2018. Sorry, 2018. I had to think about that for a minute. And then the SALT ED study, which was published also in 2018. So it was the same study group that studied over 29,000 patients. And what they did is they evaluated ICU and non-ICU patients, comparing saline to that more balanced solution, so LR and plasma IA. And the bottom line, so they looked at all different patient types. They weren't just septic. They were all from all over the hospital, literally the ED, ICU, OR, everywhere, all over the hospital. And what they found was that when saline was administered, patients were more prone to developing kidney injury. And what the other thing we're finding is that patients are developing, and when they're using a lot of saline, they're developing an acidosis. And I'll talk about some of the data with DKA patients, but I think the SMART and SALT ED trials were the biggest trials that made us kind of take pause and question why we give what we give. Now, with that said, I will tell you, in the trauma world, they figured this out a long time ago. And I know our trauma surgeons, I want to say, gosh, at least 15 plus years ago, stopped using saline as a resuscitation fluid. Nephrologists have known about it for a long time, right? But I think one of the really tough things in critical care is nephrology is always a consult service. They're not an admission service, or they're not, the service that manages patients in most hospitals. And so, for nephrology to make massive changes at bedside, it's just more challenging for them because they're in a consultative type role.
So as we think about the solution types, so we talked about isotonic solutions, which those were the three you mentioned. And it's interesting because isotonic, we have to remember that they're very different solutions, even though they're in one grouping, right? So they're not the same. So I think you bring up a good point that it's not benign. All these solutions are not the same. And you've really showed us that. In regards to the literature, where it talked about really looking at what we're giving and is it the right thing to give. So now let's talk about the literature when it comes to our sepsis population. I've been reading, of course, you and I, sepsis very near and dear to our hearts, this patient population. And we know that balanced solutions are what the guidelines suggest that we really focus on in that patient population. Are there other populations where maybe we might not focus on balanced solutions as much, or maybe it could be detrimental if we use balanced solution for these types of patients? What are your thoughts?
Yeah, well, I think just to kind of wrap up, like sepsis. So in the SMART trial, they actually did a sub-analysis specifically of septic shock patients and found that they actually had a higher mortality when saline was given as a resuscitative fluid. So it was an ad hoc analysis, so you have to take it for what it is. But I think there definitely was a signal there that perhaps we should be questioning the use of saline in our septic shock patients. And kidney injury is probably one of the biggest things we worry about. So not only could it be the fluid type, but we also know from like the FRESH trial, for example, that, over resuscitation with fluid can lead to kidney injury as well. And, when you look at the FRESH trial, when they used a stroke volume measure to guide fluid resuscitation, that they found that the group that had a stroke volume measure, about 5% of them needed renal replacement therapy, versus if you didn't have a stroke volume measure, over 17% needed renal replacement therapy. So it's not just the fluid type in sepsis, it's also the fluid amounts that we're giving. And I think, we've got to get away from this whole, this mentality of like, just give it now, and then, we can take it off later, because it doesn't work so well, over resuscitate patients. So it's complex. It's not just a type of fluid. You have to combine it with when you give it and how much you give.
Very good point. And I think if we could all have a more scientific approach to fluid management and how to give stroke volume guided fluid management is really, I think, has the highest sensitivity and specificity when it comes to, hey, does my patient, how much fluid do they need? Are they fluid responsive? And can they take and accept and receive this volume and help it forward flow to improve perfusion? So I do think that wasn't even going to be on my topic today, but you bring up a very good point. It is not just about the fluid. It's about how we give it and how we know how much to give. And Talk to me about the let's say traumatic brain injury. What are your thoughts about fluid types for that patient population?
Yeah, well, the signals that we're seeing with traumatic brain injury or patients who have cerebral edema is like perhaps so a salt-based solution is still the way to go. So specifically in neuro patients, we're still using sodium-based solutions. So I would say so that would be the one population where I'd say, be careful that, I would want to see a study specifically done in that population to say, oh yeah, go with LR or go with a balanced fluid. I think for now we're still sticking with sodium-based solutions in that
Yeah.
population.
Well, you mentioned also something about the DKA patient. So tell me what you're reading about with that patient population.
Yeah, well, I think traditionally, I mean, we know like when you've got somebody with DKA, it's interesting. A lot of people are like, oh, get the insulin started. No, the fluid needs to be your first priority, right? Because just the act of giving fluid helps with perfusion. We know these patients are so dehydrated by the time they get to the hospital, but it also, starting fluid will start to bring the glucoses down, and it helps with a lot of those counter regulatory hormones that are just completely out of whack. But in 2022, there was a really nice meta analysis that was published in DKA looking at fluid choice. And it was a meta analysis of 8 different randomized control trials. And then, just if you're not aware, like what a meta analysis is, basically, a meta analysis takes very like studies. So there's a lot of criteria for your study to be included in a meta analysis. There's very strict criteria. And then what they do is they combine the results of like studies to see, okay, when we combine all different studies, is there a signal there that kind of tells us to go one way or another? And so this was a meta-analysis of 8 randomized control trials where they compared saline to balanced fluids, specifically in DKA. And one of the things I think it's important for us to remember is we don't have a plethora of data in other patient populations, and I definitely think this should be studied. But that meta-analysis included 482 patients. So I think it definitely gives us a good signal, but would I love to see more studies done? Absolutely. But in this meta-analysis, they had 6 randomized control trials from adults, and then 2 were from pediatrics. And what we know from previous studies is that hyperchloremia, specifically in DKA, is associated with longer time to resolution because you're developing a secondary acidosis. And then likely, that's the hypothesis at least, and that the length of stay is longer. And those were a couple papers that were published. One was by Goad et al. That was published in 2019, and then Oliver et al. In 2018. So there's some papers leading up to saying, listen, fluid choice actually has an impact on outcomes and length of stay. And then there's some retrospective data in the pediatric world showing that LR, so lactated ringers, was actually associated with lower hospital cost and a lower risk of cerebral edema in the pediatric population. And that was published by Bergman et al. In 2021. So we've got these smaller studies kind of leading up to this big meta-analysis. And what they found in this meta-analysis, it was published in 2022. What they found was that when saline was used as a resuscitation fluid, the time to DKA resolution was 4 to 6 hours longer than if a balanced fluid was used. So the resolution of acidosis was a heck of a lot longer. And then what they found is that it increased the length of stay by about a day, which is a big deal in hospitals who have big log jams of patients. And then, so some other things they found was that when they used saline, that was associated with much higher serum chloride levels and lower bicarbonate levels. Again, there's this acidosis, secondary acidosis that's happening just because of the fluid choice. And so I think the bottom line, when you look at the evidence of fluid choice in DKA, right now the evidence is leaning toward more balanced solutions like LR plasma IA for DKA resuscitation. So I think the practice of using saline really should be questioned.
Absolutely. And I think for many of us who worked at the hospital or still do work at the hospital, many of these protocols were developed years ago, and we just kind of expect that we just keep going. So we need to go back and relook at what we had. I think about the one from my hospital. I had saline, right? So do we need to go back and change that and make it a more balanced solution? So definitely some things to think about. And you've given a really good perspective of what some of the literature has said and information about that. So tell me this. This is a little different off topic. Is there anything else first, though, in regards to fluid management or into fluids and disease states? Anything else that's kind of
Yeah, well, I think that, there was also some newer data in pancreatitis, acute pancreatitis, not fluid type, but it was more about fluid amount. Because I think we were all taught flood them with fluid, right? Flood them with fluid. Pancreatitis, you got to flood them with fluid. Well, but we have to remember, it's very similar to sepsis. They've got a big inflammatory response. They have capillary leak. They get significant capillary leak. And what they're finding now, there was a big systematic analysis that was published in 2023. So it was a systematic review and meta-analysis. I kind of combined systematic review and meta-analysis there and called it systematic analysis. But anyway, this was a review of 9 randomized control trials, almost 1,000 patients. And what they found was that, a more conservative fluid approach actually had better outcomes. And the waterfall study, waterfall trial, which was published in 2022, showed a 3-fold increased risk of fluid overload. When we just give fluid ad hoc, and that the risk of mortality is higher when you've got more aggressive fluid resuscitation. And so anyway, so long story short, the takeaways from that meta-analysis is that mortality risk is significantly increased when you use a very aggressive, liberal fluid approach to managing patients with severe acute pancreatitis. In fact, their fluid-related complications are increased by 2 to 3.5 times when you give a more liberal fluid approach. So again, I think we need to think about how much, not only what type of fluid we're giving, but how much fluid we're giving in some of these different disease states, especially those who have inflammation and capillary leak.
Makes total sense. Yeah, really good stuff. That's excellent. Well, thank you, Nicole. We've had a lot of great conversation. We try to keep these kind of relatively short so that we can keep people's attention. But gosh, I feel like I could talk to you all day and we would still be able to keep everyone's attention. But this has been really informative, really helping us with thinking about best practice. And I thought I might ask you just a personal question before we leave. So what would you say is one of your favorite books that you would recommend everyone to read? Now, this can be nursing or non-nursing, but of course we'll keep the number one as the book you published, and you may want to share with us what book that was.
No, one book I recently read and loved was The Women by Kristen Hanna. It was about the nurses who served in the Vietnam War. And normally I don't read, like when I read, I normally don't read like, medical-ish books at all. But I thought it was an excellent book and really paid so much respect to the nurses who were really honestly not even acknowledged that they served in the Vietnam War. And I thought it was just excellent. Again, it's called The Women by Kristen Hanna.
Awesome. I think that will be the next read for me. I would love to read that. So if someone has been listening and wants to reach out to you, where might they find you, Nicole?
Instagram, at Nicole Kupchik, TikTok at Nicole Kupchik, Facebook, Nicole Kupchik Consulting. What else do I have? LinkedIn, or my website is NicoleKupchikConsulting.com.
So make sure you get that survival guide for critical care. It's actually on my bookshelf as I'm talking right now. It's a great one, and I think you will all enjoy it. But thank you so much, everyone, today for listening, and especially thank you to Nicole for always enlightening us with suggestions for best practice and using research to help guide our care. Really appreciate you. Thank you so much for being with us.
Oh, thanks so much for having me, and thanks to everyone out there for listening, and thanks for everything you do at the bedside.
As we conclude today's episode, I remind our esteemed medical colleagues that the opinions expressed herein are solely intended for professional discussion and should not be construed as medical advice. We encourage all listeners to consult their own healthcare providers for personalized medical guidance.